Hello, everyone. On the behalf of Lambda Kappa Sigma and the Student Health Fair, we will be presenting on the management of asthma in pediatrics.
My name is Makayla, and I'm going to start off the presentation by talking about some statistics with asthma. So approximately 25 million people have asthma. Asthma is the most common chronic condition within children and is currently affecting 6.1 million children under the age of 18. The annual cost of asthma is approximately 56 billion, with a direct healthcare cost of 50.1 billion and a indirect cost of 5.9 billion. So in the year of 2019, 44.3% of children with asthma had one or more asthma attacks in the last year. So now we are going to talk about the pathophysiology, or what exactly is asthma and what happens in the body during it. So asthma is a chronic and episodic disease of the airways. So there is chronic airway inflammation, airway hyperreactivity, airflow obstruction, tightening of respiratory smooth muscle, and recurrent episodes of respiratory symptoms. So in the picture, you can see a normal airway, an asthmatic airway, and a asthmatic airway during attack, and as you can tell, it is highly inflamed and thickened. So during asthma, there is a cascade of events. So there is a activated Th2 response, which leads to an increased secretion of interleukin 4, 5, and 13 in the body. There is then an increased amount of IgE and eosinophils. And then there are increased mediators of inflammation, such as histamine and prostaglandins, which this leads to asthma symptoms. So risk factors. There actually is family history, such as genetics, and approximately 3/4 of all asthma cases are hereditary. Exposure to tobacco smoke, low birth weight or premature birth, obesity, a boy gender. So in children, boys are more likely to have asthma. By age 20, it evens out, and then by age 40, women are more likely to have asthma. Viral respiratory infections growing up, and factors favoring the Th2 phenotype. So this can be things such as high antibiotic use, a Western lifestyle, or living in an urban environment. And this actually leads to an increase in allergic disorders such as asthma. And for triggers, it is important to know your trigger and to know what triggers your asthma symptoms, your child asthma symptoms. So one is exercise, medication such as aspirin, cold air pollution such as smoke or chemicals, upper respiratory infections, and allergens. So these are different for everybody, but some common ones are trees, ragweed, dust mites, and mold spores.
So, going into how asthma is diagnosed in pediatric patients, breathing tests and symptoms are used in patients who are older than 5 years of age. However, symptoms alone are used in younger patients. This is generally because the tests that are used, such as spirometry that you can see in the little picture there, require proper patient cooperation, and it's difficult for younger patients to be able to control their breath enough for these tests. So for the age of, so for patients who are under the age of 5, diagnosis is based solely on symptoms. Providers are going to be looking for symptoms that fall under other diagnoses, such as upper respiratory infections, allergic rhinitis, and sinusitis, as symptoms do often overlap with asthma. However, generally, a patient is going to present with episodic or persistent coughing, wheezing, shortness of breath. The asthma may also be trigger induced, so while the child is exercising or doing any sort of physical activity, or when they encounter maybe dust or some sort of other allergen. Symptoms may also be worse in the early morning or early evening. So it's really important to get this information from either the patient or the parents of the child to get a proper medical history to decide how severe the symptoms are and where to start in therapy. Also, keep in mind that more than 75% of patients with asthma will have positive hypersensitivity skin tests, so history of allergies is a significant predictor for asthma.
Hello, my name is Daniela, and I'm going to be talking about the non-pharmacologic treatment for pediatric asthma. So up to 80% of children with asthma also have allergic rhinitis, and to avoid specified triggers, these are some of the things that you can do. You can do skin testing or the RAST to detect specific IgE hypersensitivity. You can reduce exposure to tobacco smoke. You can also consult an allergist to define an optimal regimen to reduce sensitivity to specific allergens. And that picture there is of the allergy skin test. And the red bumps would be indicative of an allergic reaction. So to control environmental measures, you can remove carpets from the bedroom or the living areas. You can do weekly washings of bedding and clothing in water that is hotter than 55 degrees Celsius or 130 degrees Fahrenheit. You can use specially designed mattresses or pillow covers. You can remove stuffed animals that are likely to harbor allergens. And you can keep pets outdoors or use special furnace filters to remove the airborne allergens.
So before we move into pharmacologic treatment options, I'm just going to talk a little bit about how therapy does or doesn't differ between adults and children. Keep in mind that drug therapies are not significantly different in children who are ages 5 to 11 versus those who are 12 years and older, according to the NHLBI guidelines. Children in asthma are considered those who are less than 11 years of age, and adults are actually considered those who are 12 years and older. For children who are less than 11 years of age, treatment is symptom and exacerbation driven primarily. There is significant trial data available for treatments in children who are 5 to 11 years of age, but there's less study available for children who are less than 5 years old. There are also less drug options available because of the lack of clinical trial data for those who are younger than 5 years old. And a valve holding chamber is used for both adults and children when using a multi-dose inhaler. This is just one of the types of inhalers that can be used. It's also recommended that a face mask and a valve holding chamber, as the one that you can see in the picture there, be used for very young children. As I said before, it can be difficult for children to have that controlled and deep inhaled breath to get a proper dose from the inhaler. So chambers like this can help the child get the proper dose. Also, a dry powder inhaler can be used in children who are 5 years and older. Some considerations for adults. There is extensive clinical trial data available for asthma as it is a very prevalent disease state for adults. There's also step down and step up methods to optimize care for adults. And a lot of this has to do with the validated asthma control test that is available for adults to assess control and make changes in therapy. There are also combination therapies that are now on the market available that are approved for those who are 12 years and older that include both rescue relief and scheduled relief treatments so that a patient is only using one inhaler for both their as needed asthma relief and their scheduled everyday asthma relief.
All right, so we're going to start with talking about the pharmacologic treatment options for pediatric patients with asthma. We're going to start with the age group of 0 to 4 years old. The first step is to start with a rescue inhaler to provide quick symptom relief, and it will be taken as needed. An example of a medication for this is albuterol. The next step would be to take an inhaled corticosteroid. This is an inhaler to deliver medication that reduces inflammation of the lungs. An example of this would be fluticasone or budesonide, but there are also others. The next step, if this doesn't seem to work, would be to increase that dose of the inhaled corticosteroid. The next option would be switch to a combination inhaler that both reduces inflammation and opens up the lungs. This would be called a long-acting beta agonist, and an example of this would be budesonide formoterol, but there are also other options. The next step, if that doesn't seem to work, is to increase that dose of the combination inhaler. Lastly, if nothing else seems to work, we will add a oral medication to reduce inflammation, which will be delivered systemically. An example of this would be prednisolone. All right, now we're going to talk about the treatment options for ages 5 to 11. The first step, like the ages 0 to 4 would be to start with the rescue inhalers such as albuterol, and that will be taken as needed. The next step would be to also use an inhaled corticosteroid, which will deliver medication and that will reduce the inflammation of the lungs. And the four examples are fluticasone, mometasone, budesonide, but there are also others. The next would be to switch to an inhaled corticosteroid that is in combination with formoterol specifically, which will open up the lungs. And the example of this would be budesonide and formoterol. If that doesn't seem to work, you would increase the dose of the combination inhaler like before. Next, you would switch back to an inhaled corticosteroid, but this would be a high dose inhaled corticosteroid. And then it would be in combination with a medication that opens up the lungs, a long-acting beta agonist. So examples are fluticasone, mometasone, and budesonide. Lastly, like the other age group, you would add an oral medication to reduce inflammation, such as prednisolone. Okay, now we're going to talk about the roles of the pharmacist. Many patients, mostly pediatric patients, are known to have poor inhaler technique. It's important for pharmacists to demonstrate proper inhaler technique to each patient to ensure proper administration of the medication. Both children and their caregivers should be able to properly administer their medication. While pediatric patients may appear to demonstrate proper inhaler technique, it's important to continue to reassess the patient to ensure proper administration. It's also important to instruct the patient and caregiver when to use the inhaler or take their medication. Some inhalers are meant to be used every day, and some can be taken as needed. Lastly, a pharmacist can also counsel the patient and their family on their asthma action plan. This plan is customized for the best management of the patient's asthma based on the symptoms they are experiencing. It is often provided by their doctor, and it's important to follow.
And I'm going to be talking about the future directions for pediatric asthma. So to predict which patients are most likely to respond to the anti-leukotriene agents, we have biomarkers, pharmacogenomics, genotypic markers, and novel receptor antagonists. So for the biomarkers, the degree of the leukotriene overproduction itself is the biomarker. In one study, a correlation between urinary LTE4 and responsiveness was found among mild to moderate asthmatics. However, this was not clinically useful data. For pharmacogenomics, genetic variation in the transporter gene, the SLCO2B1 gene, an association with variation in Montelukast plasma levels and of response to Montelukast among asthmatics would be used in future directions to predict which patients are most likely to respond to an anti-leukotriene agent. Genotypic markers, so polymorphisms in genes encoding the 5-LO and the LTC4S, which is more common in 20 to 40% of asthmatics. So there's a possible relationship of the variant allele and clinical response. And then finally, we have the novel receptor antagonist. So a dual cis-LT1R and the cis-LT2 antagonist showed almost identical ability to block the allergen-induced early and late phase changes in lung function. And for patient population, an allergen-challenged atopic mild asthmatic. So biomarkers that reflect the leukotriene production are an active area of investigation. And although these markers are not currently used in clinical practice, one study found that the mean levels of the ex vivo cis-LT production was stimulated by whole blood leukocytes were higher in patients that were deemed to be responders to the cis-LT1 antagonist than in non-responders. But the sensitivity and specificity of this parameter were inadequate to guide actual clinical decision making. In the largest series reported, even though it was only comprising of 48 patients, a correlation among mild to moderate asthmatics between urinary LTE4 and responsiveness was observed, but again, the sensitivity and specificity were inadequate to be clinically useful. So these are some future directions, however, they are not all being used right now clinically. However, these are the future directions that they could take to be able to predict which patients are most likely to respond to an anti-leukotriene agent. So there's more to look forward to in the future. And finally, these are the resources that we use for our presentation. Thank you very much for your time and attention, and we hope that this presentation was helpful for you to learn some awareness about pediatric asthma. Thank you.